The perioperative management of a diabetic patient undergoing surgery requires meticulous planning to prevent complications such as hyperglycemia, hypoglycemia, infections, and delayed wound healing. Below is a detailed approach. Preoperative management. 1. Assessment. History and physical examination. Assess glycemic control history, complications, neuropathy, nephropathy, cardiovascular disease, and medications. Laboratory tests. HbA1c for long-term glycemic control. Fasting blood glucose. Electrolytes, renal function tests, and urine for ketones. Cardiac evaluation. Due to increased cardiovascular risk, consider ECG or stress tests for patients with known or suspected cardiac issues. 2. Optimization of glycemic control. Aim for preoperative blood glucose levels between 100 to 180 milligrams per deciliter. Avoid hypoglycemia 70 milligrams per deciliter. Adjust oral hypoglycemic agents or insulin regimen under guidance. 3. Adjustment of medications. Oral hypoglycemics. Hold metformin 24 to 48 hours before surgery. Risk of lactic acidosis. Sulfonylureas, e.g. glibenclamide, should be stopped the evening before surgery to avoid hypoglycemia. Insulin. Long-acting insulin may be continued at a reduced dose. Short-acting insulin may be withheld on the morning of surgery, depending on fasting glucose levels. 4. Preoperative instructions. Schedule the patient for the first procedure of the day to minimize fasting time. Provide instructions for fasting and hydration. Inform the surgical and anesthesia teams about the patient's diabetic status. Intraoperative management. 1. Monitoring. Continuous glucose monitoring or frequent checks every 1 to 2 hours. Monitor vital signs, fluid balance, and electrolytes. 2. Blood glucose control. Target intraoperative glucose levels 140 to 180 milligrams per deciliter. Avoid extremes of hyperglycemia or hypoglycemia. 3. Insulin therapy. Use intravenous IV insulin infusion for type 1 diabetics or poorly controlled type 2 diabetics. Regular insulin is preferred, and a sliding scale or continuous infusion can be used. 4. Fluids. Use balanced crystalloids like normal saline or lactated ringers. Avoid dextrose unless hypoglycemia occurs or the patient is on insulin infusion. 5. Anesthesia considerations. General anesthesia can affect glucose metabolism. Coordinate with the anesthesiologist for tailored management. Post-operative management. 1. Glycemic monitoring. Monitor blood glucose levels every 4 to 6 hours for non-critically ill patients and more frequently for critically ill patients. Target blood glucose levels 100 to 180 milliliters. 2. Insulin adjustments. Resume basal insulin as soon as oral intake is permitted. Supplement with short-acting insulin if necessary based on glucose levels. Restart oral hypoglycemic agents cautiously once normal diet resumes. 3. Complications monitoring. Watch for signs of hypoglycemia, hyperglycemia, ketoacidosis, or hyperosmolar states. Monitor for infections, especially at the surgical site. 4. Nutritional support. Start with a clear liquid diet and progress to a regular diabetic diet. Avoid prolonged fasting to minimize catabolic stress. 5. Pain management. Use appropriate analgesics to reduce stress-induced hyperglycemia. 6. Wound care. Ensure meticulous aseptic technique during dressing changes. Optimize nutrition and glycemic control to support healing. 7. Follow-up. Plan outpatient follow-up for long-term diabetes management and wound healing evaluation. Special considerations. Emergency surgery. Immediate blood glucose control with IV insulin and fluids. Check for ketones to rule out diabetic ketoacidosis. High-risk patients. Patients with end organ damage, e.g. renal impairment, require close monitoring and dose adjustments. Effective communication between the surgical, anesthetic, and diabetic care teams is crucial to ensure a smooth perioperative course.